My name is Norm Volsky, your host, and this is the Digital Health Heavyweights podcast.
Thanks, Norm. It's an honor to be here, and it's been fun to work with you over the years.
Hello, and welcome to the Digital Health Heavyweights podcast with your host, Norm Volsky. And today we are thrilled to be joined by founder and CEO of Garner Health, Nick Reber. Nick, welcome to the podcast.
Hey, Norm. Thanks for having me.
Absolutely. Really excited to have you. I think this is the first podcast we're filming in 2025. Super excited to get started with another year of our podcast. And for all of our viewers and listeners that are not as familiar with Nick or his company, Garner Health, before founding Garner, Nick served on the leadership team at Oscar Health, where he focused on analytics and provider network development and helped oversee the firm's growth to over $2 billion in revenue. Prior to that, Nick was a partner at Bridgewater Associates, where he served as a co-head of research analytics. And then people not familiar with Garner Health, which I doubt there are many, Garner Health's mission is to transform the healthcare economy, delivering high quality and affordable care for all. Nick has led Garner Health to compile a database of over 6 billion medical records of 320 million patients to evaluate the efficacy of healthcare providers, building a doctor recommendation app, medical cost reimbursement platform, Garner DataPro, a concierge service, and more. Super excited to have you on the podcast and for you to tell us all about building Garner into what it is today, and more excitingly, even what's to look forward to in the future.
Great. Looking forward to it.
All right. Fantastic. So what inspired you to get into healthcare after 10 years in the hedge fund world at Bridgewater?
Yeah. So, first and foremost, I was a patient myself. So I had a back pain, actually, which was misdiagnosed. I ended up having a thoracic spine surgery, which was not the right surgery. It turns out retrospectively, now that I'm well educated on these things. And then I got no relief from that, but then I also had a complication on the surgery and then required a revision and many more. And so I ended up being at about surgery 5. And I think on my 4th surgery, I just started to see all of the crazy things and waste in the system. I got wheeled out in a wheelchair, even though I could walk. And I sort of followed the thread on who's paying for this wheelchair. And I was like, I don't want the wheelchair. They're like, no, it's yours. You paid for it. I was like, well, your insurance paid for it. I was like, well, who's my insurance? And I pulled this thread. And it turned out my employer was self-funded, because most employers are, and I was an equity holder in the business, which meant I was paying for it. And I was like, this is crazy. And at the same time as that, I was also studying equilibrium real interest rates in the economy, which sounds very highfalutin, but what I was really looking at was the propensity for people to save money based on their income inequality. And what I started to realize is we have the worst income inequality basically at any point in almost the last 100 years. And most of it is driven by our healthcare system, because employees have gotten basically no real wage increases in median income in the last 30, 40 years. But what they have gotten is a ton of money that has gone into healthcare benefits that mostly hasn't delivered any. In fact, it's delivered worse health outcomes. And so I just kind of got fired up about it, and I said, let's go. I think there's a place for data and financial incentives, which are things that I was pretty good at from my previous world, in the healthcare world, and I sort of dove in, and this was, 10 plus years ago.
Yeah, no, I think the only way this industry moves forward is some outsiders come in and show us and share some new perspectives. We very much appreciate you changing your career path to tackle these issues. So walk us through your time at Oscar Health, and what was it like when you got there versus when you left?
Yeah, so I joined, relatively early. We had just launched on the Obamacare exchanges, which were just going live, and the team had sort of gotten its license and was like, here we go, we're now an insurance company.
Yeah.
And then it was, holy smokes, we now have medical losses that are through the roof. So our we were running a medical loss ratio of 120+%, which basically means for every $100 in premium you bring in, you spend $120 plus, then you have to pay your overhead. Not a great economic business in that way. And we were really figuring out the basics of what it meant to really run a health plan. We were reimbursing every out-of-network charge at 100% of charges, because we just thought that's what you had to do. And anyway, for everybody who's gotten deep on that, that's not what you want to do.
Yeah.
And so it was really the Wild West. We had we had basically all rental networks, initially in New York, then New Jersey, and then, across the country, LA. And so, one of the things that my team was responsible for was basically overseeing really how are we going to build a whole, the product of the network. And so how are we going to turn New York from a rental network to a directly contracted network, same thing with the Texas markets, and then take that model and roll it out around the country. And then at the same time, build a whole lot of the mechanisms needed to actually control healthcare costs, whether those were contractual, such as don't pay charges when somebody charges, $1 million out of network emergency room claim, but also, how are we going to steer within our networks and think about that and control costs in a lot of other ways. So that was sort of what we spent a lot of time on.
And what would you say your greatest accomplishments were in your time at Oscar?
Well, I mean, it's very easy to take credit for. I had a large team, who did 99% of it. So I would say the big thing was we went from 120, I think 1% medical loss ratio at 100 million in premium. Then we're able to get that down into about an 85 at a 10x bigger premium level. And I think the key of it was really taking control of our provider relationships around the country. And we built a model that we launched 30 cities in a couple of years from totally ground up network builds. So, and those who have built networks know that there's a lot that goes into signing literally 100,000 contracts or more we signed to have the relationships with providers and do so at reasonably economic terms such that we could actually afford to launch a product that was, that at a reasonable cost structure. So I'd say that's my role in it was modest, but that's what the team I think was able to accomplish.
Yeah, it's a huge accomplishment. What were your greatest learnings at Oscar? Since it was probably your first time like operating within a growth stage, like super high growth company.
Yeah, I mean, there's everything. I'd say from the healthcare side, the main understanding was all of the massive constraints that you have in being a health plan. Obviously, there is regulatory, and we had to have lots of meetings to state capitals to sit with the departments of health and insurance and these sorts of things.
And you were in those meetings personally?
Yeah, several of them, several of them as needed. Largely I would be on when we would, we're launching a new product, a new network. We have network adequacy. We have these sorts of things. So, I get to see a little bit of what it's really like to operate in a deeply regulated environment, et cetera, but also what the economic constraints of the business are, particularly as it relates to the payer-provider negotiations. And so really, you think about the product of an insurance company is really its insurance network. That's what people buy. They buy the network discounts. You build that product, you have tremendous constraints. Really, it means that your ultimate consumer is as much the hospital systems and the doctors as it is your actual either employers or individual members. So you start to really, I got a real appreciation for how the sausage gets made around delivering the real product of healthcare and insurance networks and things of that nature. And I think I came in with a lot of relatively naive theoretical views from an economist standpoint of wouldn't it be great if healthcare could just look like every other market. And you can think a little bit about what Garner is as a way to apply a more sensible economic framework, but do it in the context of the reality of how actually healthcare really works and the deep vested interests and incentives and systems that are set up today. So I really got a real crash course education on those matters.
So you mentioned, your own personal experience, with your cervical spine issue. And, in terms of your example where, they put you in a wheelchair, you say you don't want it or need it, and they said, well, you paid for it already. I think that just is a good example of like the itemized nature of healthcare where, $500 for 2 Advil and $1,000 for wheelchair transport, from your room to your car. Like there's a lot of excessive charging and spending done all like itemized on a receipt as opposed to, full bundles and just paying for outcomes. So kind of walk me through like all of the research and all the different models that you dove in deeply to, create this new way of looking at healthcare spending over at Garner?
Yeah, I think ultimately one of the realizations when you think about the first thing is like, what do you want to even analyze? And what you need to start to think about it, because there's so many different ways to cut it. I mean, you can think about it as pharmacy and inpatient and outpatient and physician and all these different types of facilities and all these sorts of things. The first realization, I think, is that the essential product of healthcare is the doctor or the provider. And the reason for that is basically that's how people think about getting care. Like, who am I going to for my knee pain? It's Dr. Jones, it's Dr. Smith. And actually, the data bears that out. At Oscar, we had most people would actually use our tools to search and find a doctor. And if they weren't using our digital search tools, they were using somebody else's, like a Yelp or a ZocDoc or a whatever. But then we would try to get them to switch their site of service for surgery or their drug they were on or whatever. And they'd be like, no, my doctor said should do this. No way. So the first thing you have to do is you have to start to realize that the way to cut it, the most useful lens on which to view, through which to view performance is through the doctor or provider's lens. And that was sort of the first insight. And then if you look at it like any economic good, it's just like a t-shirt, a car, or whatever. If you're Kelley Blue Book and you're looking at cars, you want to look at their cost and their quality. And it turned out what has been out there in the industry on that topic has been just really awful, in my view. And it was invented in the 90s, has not evolved since, and really did not accurately assess the cost and quality or efficiency of that product of each individual doctor. And so I can talk about exactly how we've done that, but that was the first thing: is what is the unit, and then just really trying to look at what was out there in the industry and feeling dissatisfied with the analytics that were there.
Okay. Yeah, it makes a ton of sense. How do we not only improve healthcare outcomes, but solve, the healthcare efficiency, issues and put money back in the pockets of employees?
Well, I think you have to understand if you're going to solve a problem. So at Garner, our goal is to actually really change how the healthcare system works. It's sort of gaudy and ambitious.
It's an ambitious goal.
We'll see how we do. You have to be humble.
You're doing pretty good so far, so you're on the right track.
We got a lot left to do, but when you're trying to solve something, the basic thing that's important is to understand, well, what is the core problem? What is the cause of the problem today? And my view on that is the market is broken. And people talk a lot, and I know you talked about healthcare, the incentives are wrong for the providers. Our view is that really the change needs to start with better incentives for members or for patients. Because I'd
say the incentives with the benefits leaders are off.
Totally.
I've said it till I'm blue in the face. A benefits leader at a big Fortune 500 company invests in something that changes the trajectory of their company because they're able to curb healthcare spend at 3% year over year increases as opposed to 10% on average. They get a nice pat on the back for taking a huge risk. If they get that wrong, they probably get shown the door. There's no major incentive for an employer's benefits leader to take a huge risk because they don't get much reward if the decision goes well. If it goes poorly, they most likely get fired. So there's many incentives in the healthcare ecosystem that are completely backwards or upside down.
Totally. I agree. And I think the basic thing, people have talked a lot about doctors' incentives and hospital incentives and largely changing those incentives via value-based care. Turns out it doesn't really work much at all. I can go into the reasons why, but ultimately it doesn't change whether you pay for your meal a la carte or all you can eat. It's just a question of how many people are in that restaurant. And so what we believe is that what you really need to change is the patient volume. How many people are going to go into that restaurant? How many people are going to go into that doctor's office? That's what determines the profitability of the restaurant or the doctor's office. And so what Garner is really an effort to give more information about quality, but also critically change the natural financial incentives in the health plan so that a patient that goes into a doctor's office, they're sick, their kid's sick, they're wondering where to go. We want to have it so that if they take the high quality, efficient option, that's, by the way, nearer them, easier to get to, better health outcomes, all of that, then they get a substantially less or zero medical bill out of that. And if not, they can ask their neighbor and do whatever, but it's going to be a little more costly. And I think that's how the system needs to work. If you're going to start routing more patients, and basically rewarding doctors who are doing great with more volume, with more money, and penalizing those that maybe aren't doing the best by losing out. And so that's the essence of what we're trying to build.
The other just very frustrating part of healthcare is there's almost zero correlation between cost and quality. And that's what consumers, especially in the US, have a really hard time comprehending, because in just about everything in the US, like just general, way of living, it's like, well, if you pay more for something, you're going to get a better quality product or service. In healthcare, not that way. Like, there are plenty of examples. I'll use one as just like a small example that will, be indicative of everything else. Like, you could have a MRI scan that's $5,000 inside the four walls of a major, big academic medical center, main campus. And not only is it going to be $5,000, but there's a chance that it might be on a MRI machine that's 20 years or 15 or 10 years old. And then like down the street, 5 minutes, is a independent radiology practice that has top of the line equipment, and it's only $500 for that scan. So not only are you paying a tenth of the price, you're also getting a much higher quality image for a radiologist to read. And like that scenario happens all the time. And someone in, the American mindset would say, well, 5,000 is better than 500. But like in reality, sometimes it's equal. Many times, even the more expensive one is a lot worse, in quality. So I think it's just such a unique, intricacy of this space is the quality cost matrix is completely skewed compared to how most consumers think about, price and quality.
Yeah, and we tested that. I mean, when I was at Oscar, we tested dollar signs, 1, 2, 3, $4 like you'd have on an open table app or whatever. And to your point, everybody was like, well, I'm obviously going to the $4 signs because, and we're like, no, you don't want $4 signs, you want one, right? And people are like, no, but that's the best.
And they're like, this is my health. That's the last thing I'm going to skimp on.
It's my health, and I'm insured. I'm fully insured, so like, who cares? I'm going to be through my deductible anyway. Who cares, And so what I think you have to do is both, you can, and it's a long haul to educate every consumer, which we're on the process of, on that you can get quality without paying more. But at the very least, what's much easier to disentangle is that I'm insured, so who cares? It's somebody else's money thing. That you can disentangle if you have the right financial incentives actually pretty quickly. Say, hey, listen, if you get with the program, go to these high quality doctors, you're going to pay zero. And if you go anywhere else, it's going to cost you money, not your employer's money. It's going to cost you a lot of money. So I think those are the two parts that we try to work on.
Yeah, plan design can shift a lot of volume
Exactly.
positively for the employer, for a health plan, or you name it. What inspired you specifically to found Garner?
Well, it's sort of this conversation and basically having the very specific view that I think everybody in the industry was starting to talk about, and now is even more talking about variable provider performance, like we're talking about. Like, we're not the first people to say cost and quality are unrelated, and then if you go to the high quality providers, you're going to cost less and save a lot of money and all that stuff. But that I got the view that to your last point, that plan design and financial incentives, they all really, really matter. And the data really matters of how do you actually measure this stuff. And that neither was done very well. And that there were a bunch of these structural barriers. So I was sitting there and it was like, to this day, you cannot tier within a BUCA network and do plan design without a lot of special exemptions to actually drive more patient volume where it really ought to be going. And so, I felt initially I thought, let me join, let me research, let me find other people who are doing this and solving this problem. And I couldn't find anybody. And so I was like, all right, I guess we got to start this dumb company here now, because I don't think anybody else is going to solve it. And so that was it, is feeling like we had something to say both on the data and the sort of plan design element in a way that didn't exist today. And that's where we started 6-7 years ago.
Okay. So Garner Health has the United States largest claims database, and with over 6 billion medical records from 320 million patients. What is some of the most surprising findings you and your team analyzed, through all that data?
Yeah, I mean, there's a whole bunch. When you get deep on this stuff, you find all this crazy, interesting, fascinating stuff on a daily basis. I mean, the biggest one that I'm always shocked with, even as I go through my own personal care, is just how crazy different this stuff is at places that you would think would be, that would be all over it. I'd say one of the interesting things is that there's zero correlation, as we found, from where you went to med school, where you did your training. The prestige of the organization is incredibly lowly correlated, very positively correlated, but very minimally. That all of the things that people are used to thinking about, I get asked all the time, like, well, if I don't have access to data, like, what can I look at? Is it people who went to this great med school or residency program? Turns out, no, not really. That none of that stuff correlates. There's some tiny stuff about getting, folks, there's some tiny correlation on age, experience and volume matters a little, but the bigger thing is that none of that matters, that the bigger thing is just looking at the track record of how the doctors practice, and everything else that I sort of thought would correlate with performance actually does not much at all correlate with it. And so that was sort of interesting to me. I thought we were going to go in and aggregate all this, who published more literature and, these sorts of, who's the chair of the department, and aggregate that, and that would be incredibly useful. And it turns out that's totally useless. And, you're way better off having the doctor who went to the University of American Samoa but has really low historical complication rates than you are the doctor that is prestige, but doesn't perform that a lot with high complication rates.
Gotcha. So prestige means nothing. It's all about results.
I think, anyway, maybe not 100% of the time in not every industry, but in the one in which we study, that seems to be the case.
Very interesting. Well, I've seen something similar in search work as well. So, just because you're a big name doesn't mean, you do great work and vice versa. So,
indeed.
I think there's a lot of industries, that actually rings true. What has been the greatest challenge in building Garner so far?
Well, I would say, for us, it's really, we got, I think, somewhat fortunate, particularly if you take, the pandemic was, I think, challenging for a lot of folks in a lot of different ways. For us, people were not really interested in improving, healthcare trend when there wasn't nobody who's going to the doctor. So once we got past that, I would say the bigger thing for us has been, we got somewhat lucky and fortunate that I think the story of variable provider performance and the need to control cost trends have really been at the forefront of the conversation, at least with sophisticated brokers, consultants, and employers. And so really it's been, how do we assemble a great team to satisfy the market demand for this? And that's still our biggest issue, is making sure that we can have all the great folks to improve our product as fast as we need to, service our clients as fast as we need to, et cetera. So that's honestly been our biggest challenge, is continuing to make sure that we deliver consistent, high-quality results every day, mostly for our employers, brokers, and other provider groups that we work with.
Walk us through how you built the largest claims database in the United States. That's like a very, I would imagine, cumbersome thing to do. And there's, definitely groups that have large claims databases that have much deeper pockets than Garner.
Yeah, well, right. And when you start off and we're like, 3 people in a dream and, that sort of thing, I would say we got fortunate in timing, at least to start, that we were able to knock on the door of folks that had access to claims data, aggregated claims data, whether it's a clearinghouse, an aggregator, an actuarial firm, et cetera, and say, hey, we'd love to be able to purchase some of your data. And we were pretty early on. I mean, if you're talking about 2018 or whatever, cloud architectures were just really getting going. The actual compute needed to analyze 320 million patient records, like that didn't really exist in the mid 2010s. Like, we were just being able to analyze that stuff performantly. And so we talked to a lot of people who were just beginning to build a department around monetizing their claims data. And so we were able to early on sort of get a foot in the door with some, going and knocking on a bunch of windows. And then as we've grown, our data set has grown organically with it. So the more employers, health plans, providers, coalitions, et cetera, that we work with, the more our business grows organically from a data perspective. And we have a lot of entities that actually want us to train their models. So if we work with a health plan and they're rolling us out and want to control their medical loss ratios, well, they want to make sure we have all their data and that we train our models so that we help improve their performance as best we can. And so that's been, I think, a natural tailwind for us. Is just everybody actually wants us not to just access their data, but many folks actually want us to train our models using their data, and then help them see the results. And so that's, I think, a very natural synergy that we have in the business.
I love that. In terms of building your doctor recommendation system, what are the parameters of someone being classified as an excellent healthcare provider, within their specialty?
Yeah, so I would say ultimately the way we think about it, that's very different than what's been out there to date. Almost everyone uses these things called episode groupers. And if you look at, these are what the carriers use. It's 98% of the weight on your carrier website for who gets a tier 1 designation. But it's actually anybody who else is analyzing it, like go deep, read their methodology. They're all using these episode groupers.
Yeah.
Optum, the Truven one, whatever. And they're all based on the stuff invented in the 90s. And all it does is give you one number, which is a cost per patient. And it turns out that cost per patient is driven mostly by randomness of who shows up at your door.
Yeah.
And not so much by doctor performance in ways we can get into. And so to get around that, what we've done is we've built everything bottoms up. So we measure every little decision a doctor does, and in every sub-disease and subcomponent, what were the outcomes? So our overall, we are measuring doctors' cost and total cost of care and quality of care, but we're doing it via looking at these 530 some odd metrics. And it's everything like you noted. So on the cost side, we're looking at not only what is the doctor bill, but where do they send their MRIs? Do they do their surgeries inpatient or outpatient? What drugs do they prescribe for which patients? Et cetera, et cetera. How are they doing controlling utilization? And on the quality side, we're going to make sure two things. We're going to make sure the doctors are following the right evidence-based guidelines. So PT before surgery. This is the right test. Make sure you're actually giving this person their cancer screening. So all of the right guidelines, and then also outcomes. So complication rates, revision surgery rates, hospitalization rates, disease progression, mortality, and on and on. And so it's sort of those things all bubbled up from these 500 metrics that give us an overall read in 80 some odd subspecialties on again, that total cost of care and then the health outcomes generated.
So this might be getting too much into the weeds, but how do you solve for the issue that, a lot of providers work for a large health system and are paid on salary, like they're not paid on profitability or performance or anything like that. And although what you're doing, within Garner is like trying to penalize doctors that are referring to inefficient areas that are high cost as opposed to, ideally low cost, while the hospital is like, hey, you're my salaried employee, and that is part of how we justify your salary and pay for you to work here, is because we ask you to refer to an inpatient imaging or refer to, our primary care physicians that, tend to cost more and not necessarily have improved clinical quality. Like, totally understand what you guys are trying to do. Love the mission, but like, how much do the hospitals have control over their employees?
Well, the data would show, what's fascinating is you see the data, it would show you not a ton. To a certain degree, a little bit, and by direction, yes, like hospitals that pay their doctors that have surgery quotas, things like that, like do have a little bit higher incidence of surgery. And, that does matter for sure. But even within that, you have massive variations of doctors in the same hospital. And if you think about it, a lot of these hospital systems have bought up all the other nearby community centers and doctors and whatever. They may not even be on the same EMR, much less have a harmonized performance management system. And a lot of the hospitals that we talk to don't even know which of their doctors are doing things well and poorly and have no idea. So I would say there's massive variation still in these hospitals. Yes, they're influenced by their overall compensation, but even within that, there are a lot of doctors that are doing the right thing, even if their compensation doesn't push them that way. And even when the compensation tells them to do the right thing, they may not always be doing the right thing, depending on which doctor it is. And so, that's, I think, the core. There's a ton of opportunity to identify those top performers. And then over time, what we're starting to do is we're starting to get more and more phone calls from hospital systems that are interested in this topic, that want to improve their value-based care, that want more commercial volume from entities like us. and or say, hey, help me understand who my top and bottom performers are and how do I do better, and et cetera. So that's actually a fast growing part of our business as well, is to help those folks out and give them the data and the commercial volume that they need in order to grow their business.
Gotcha. How does Garner Health reimburse an employee for medical costs, including copays, visits, medical tests, even surgeries? And, who's paying for that reimbursement?
Yeah, so ultimately the way that it typically works is an employer, we work with employers, and they can be fully insured, level funded, or self-funded. And they'll typically be on a large BUCA network, although we have folks with independent TPAs, we have folks with directly contracted networks, we have reference-based pricing. So it's really anything that you have. And what we do is we layer on top of the plan, and then we work with the employer to cover the employee out of pocket if and only if the employee engages and sees one of the doctors that we recommend. And now ultimately that is the employer's money. Many times employers are working with a higher deductible plan in order to fund some of these incentive dollars, and that becomes a really good trade for them and the employees. But ultimately, and we have a bunch of pricing schemes that offer fully guaranteed caps and trends and make it like we think a real no-brainer in terms of the ROI. Ultimately, the employer is funding the out-of-pocket when people engage, and just like they fund their self-funded medical benefit or whatever it is. And then again, we put our money where our mouth is and such that the employers aren't paying for stuff and then having a high cost trend and all that stuff.
Walk us through the Garner DataPro solution.
Sure. So yeah, I'd say seen a lot of inbound demand from providers throughout the ecosystem. And really it goes into two camps. We have a lot of primary care groups or some multi-specialty that wants to take risk or demonstrate their value and really are tired with the old carrier directories and want to understand what's going to happen to my patients when I refer them to a specialist in my community. And that could be in a community that they have a lot of volume, or it could be they're trying to build a national model. We have a DataPro referrals product that helps understand in every community not only who's in every network, but also and appointment availability, but also who's actually delivering high quality, low cost care. And so that's sort of half of what we do on the DataPro side. And then the other half is insights, where we work with groups on their own population and hospital systems that are trying to improve their CMS advanced payment initiatives or go at risk, improve their commercial contracts, et cetera. And we help them understand which providers are helping them along those lines and which maybe could use some education, and doing that in a very nitty-gritty numerator, denominator, clinically valid way. So we call that DataPro Insights. And so that's really what we do on the DataPro side. It's really taking our data and arming providers who want to be a source of change and improve quality with that information.
That's great. There's just so much that you've added to the platform and just continued to iterate on, over at Garner. What's next for Garner? Are there any emerging healthcare trends or tech that you're particularly excited to leverage in the future?
Well, I'd say we've got, our number one focus is going to be continue to work with our employer and provider groups. I'd say generally, one of the things we've probably done right is double down on the core things we want to do well and continue to leverage those and get better.
Yeah.
So you're going to see us continue to add more data, make that better, become even more the market standard for how do you evaluate provider performance. You'll see us add some new things to make it easier, better to search, find, and understand care. See, we're just adding everything like appointment booking in the app, live linking, like a whole bunch of things like that to make it even just a little easier, simpler, better. And finding ways to make our financial incentives even faster, better, easier, I would say. And then similarly on the provider side, better reporting, better understanding. I would say the only other demand that we get a lot and which we're continuing to lean into is we have more and more employers that want to go at risk with us or want us to take risk, and we're actually really excited about that. And candidly, if we had, our financial results of the business would even the more risk we can take, the better for our clients, we think, and for us. So you'll see us also do that, work with even some very large employers who are like, I don't want to be in this risk game. I'm tired of having uncertainty, and that we're happy to offload this. And so we're excited about that opportunity as well to basically take more downside risk and put our money where our mouth is. So you're not going to see
Employers
anything.
love that, you
Yeah.
know, delegating risk to someone else. That's good.
And we think more and more and more it's going to be the trend is employers are going to be out of that game. And there are ways to do that without going back to the old fully insured BUCA model, we think.
I would agree. I would agree. As everyone who studies this market, healthcare extremely fragmented. Can you walk us through how Garner, contributes to addressing this fragmentation and making it less so?
Yeah. And you, by the way, just so I understand, you mean what part of fragmentation, just so I understand?
I think just the healthcare industry in general is very fragmented. I think it creates so much confusion that it's hard to navigate.
Yeah, I think certainly in the employee benefit side, that is definitely true. I mean, you've got the average large employer has 16 different vendors and point solutions in right now. It's overwhelming. I think ultimately what you'll see in the industry over the next few years is that things will simplify. You'll have your health plan. You'll have an entity that's either your health plan or somebody that looks like Garner that really helps you search, navigate, understand that. And we think the core essential element of that is you need really good data and you need financial incentives. And that I think then you'll see a lot of providers sort of just join the networks and become part of the network. So whether that's a point solution on this or whatever, you're already seeing that in a lot of areas. And that you'll have basically this layer to help search, navigate, understand your benefits, and then you'll have your network itself. And I think that'll sort of simplify and start to consolidate things a little bit. And that's what we, increasingly our clients are looking to us for is that of, I got all this complexity, how do I just make it simple? And I think ultimately you're going to have a network and you're going to have navigation of all of your benefits along with incentives. And I think that's how the industry will shake out. And we obviously are working hard to simplify things for our clients along those lines.
Yeah. Well, I've been following Garner for years now. It just seems like you guys keep building off successful year after successful year. Can you walk us through your take on building, high-level teams, whether it was from your time over at Oscar or, currently as running the company over at Garner?
Yeah, it is a lot of work and there are a million things you got to get right. I would say sometimes I get asked by, startup founders, what it is, what would be my advice. I think ultimately the big thing is it's hard to manage stuff as any manager, certainly as a CEO, if you don't understand what is getting done. And so I think being in the details of what does it mean to do this job really well, and don't skip the step of getting educated deeply on, like, you could almost do the job yourself, is actually really the key, because then you can interview better, you can assess people better, you can be more quick to understand when things are off the. And I think a lot of folks, the sort of common wisdom has been something like, hire world-class people who are experts and who are better than you. And to be clear, I think that's true, but you don't want to forget that you need to be able to engage deeply in a conversation, from everything from recruiting and talent acquisition to engineering to sales. Like, if you can't know what a great sales organization looks like, how are you going to hire and hold someone accountable if they're building it? And so you have to really be in the weeds on a whole wide variety of stuff. That's certainly
And how
true
do you
as
do
CEO,
that?
but
Like, is that
across the board.
reading? Is that from doing it yourself for, a certain portion of time before you hire someone? Like, how do you gain that knowledge?
It's both. I mean, I think the first thing is a lot of people have one advisor that may help them. You need like three, because one advisor will almost, like, the odds of somebody giving you bad advice is like 50-50 every time you get an external advisor. So you need to have like three if you don't know, if you're not good at something, and you need to bounce the ideas across all of them. And then, yeah, you have to like literally get in and do it. And we've at Garner built what we call the Office of the CEO, which is a sort of a diverse team of folks that can just Swiss Army knife get into everything. And we kind of a little bit figure it out at first principles and solve the problem and then hire the person into that, not the other way around.
Yep.
And that's actually been a really big efficiency unlock is then we know what we're looking for and we can find exactly the right person and click in and make sure it's working really well.
What else do you look for, in talent, when bringing them into your organization? What are like the must-haves? Like, there are table stakes that, it's like, hey, if you have all the experience in the world and you've done it super successfully at other companies, but you don't have these things, like, you might be successful elsewhere, but you're not like Garner material.
Yeah, I would say, we designed Garner to be a pretty intense place. You don't need to work 100 hours a week, but when you're working, it's going to feel like you're working with really high talent people on very important work that we perhaps wrongly, we think the sort of fate of the healthcare world's on the line here. We got to go. So it feels intense, high focus, and high standards. And then we're really honest with each other, and I think that that's pretty important as well. So I would say there's that. And then I think the interesting thing is the world is evolving fast on technology, and the conventional wisdom 15, 20 years ago was that that delegating to humans was the best operating technique. And increasingly, I think even in non-technical domains, our best managers need to be able to talk to computers just as much as they talk to people.
Mm-hmm.
And think about systems that way. So it's a mix of those things. It's the intensity, it's the honesty, the mission focus, and then I think a degree of systems design and technology savviness is actually also really important, particularly in our management layer.
What are the most common misconceptions employees have about their healthcare options, and how can we educate them and get them to engage, more often in some of the tools being offered?
Yeah, I think it's an interesting one. We obviously talked about a huge one, which is that price does not equal quality. That's a huge one. And then I think also the big one, which given everything that's going on with, prior authorization and denials, I think people don't quite understand that their health plan, I don't really have a horse in the race because I'm not a health plan anymore, but I think their health plan is actually very much aligned with their health outcomes, and their employer is too. Like their employer and their health plan have every financial incentive to make sure they get all the care they need to be healthy. And interestingly, the providers actually don't. Because if you have a complication, the provider's getting paid double. And that's not an indictment on the providers, it's just the financial reality. Mm-hmm. And so I think we run that as we still get a little bit of my employer is trying to get me to deny care, and you have no idea how much your employers are trying to help you stay healthy and have a massive financial alignment with you on that. So we try to, I think a lot of our marketing goes to dispel that notion and educate people.
Yeah, no, I see it firsthand. Like when I go to events like Conference Board, there are benefits leaders from 8 a.m. till 5 p.m. in sessions trying to learn, trying to understand, how can I provide better healthcare for my employees? These people care and they want people to have access to all the potential avenues they need to stay healthy. So I can promise you this, I've seen it firsthand. It's not out of a lack of effort or a lack of care. Employers, health plans, they do care about their patients, and they do want to, make it as seamless and give them access to care they might not have had access to before. How do you make that a more seamless experience for employees, to navigate care and make it less stressful?
Yeah, I think particularly these days with all of everything that's going on with the pushback on denials and prior authorization, our big view is that when we look at this on the data, that if you can get folks and make it a really seamless experience upstream, then you don't need to intervene later. And that helps create a positive reinforcing cycle. So we think right now more than ever, there's going to be a focus on how do I get as upstream of all of these problems as I possibly can so I don't have to deal with them. And we think that's the solution. It's not fewer, it's probably a little bit fewer prior authorizations and more accurate and stuff like that. But by far more than that, the number one predictor is where am I upstream to start my care journey? That's the biggest predictor of whether I'm going to have a denial and all this pain downstream. Well, maybe you didn't need that surgery, or maybe you did, but it's a fight and whatever. So we think solutions that look that way, whether it's Garner or something that looks like it, that gets you upstream and avoids those sort of fights later on, is really how we're going to get ourselves out of this mess over the long term.
Do you have any data around cost savings and what the average employer saves by implementing Garner?
Yeah, when we've done our every client that we ask every client to send us their longitudinal claims data, and not 100% of them do, but those that do, on average, we've lowered medical trend by 12% in the first year relative to the national average. So national average being up 5, Garner you down about 7 on average, net of all fees, costs, et cetera. So that's about what we see. And then every employee that uses it, we save 27%. So on matched cohort, people that use the tool versus don't, it's about 27% lower. Obviously, for a bunch of reasons, not everybody uses it and you got to pay fee, but that gets you to a 12% trend reduction. But that's the basic idea is a 27% difference then equals a 12% trend reduction.
That's incredible. Like, got to be so proud of what you and your company has been able to achieve, and proof's in the pudding. Like, that data is nearly unheard of, which is awesome to hear. You've obviously scaled a company, to this point really, really effectively. What do you think are three crucial traits of a successful founder, specifically within like this digital health ecosystem?
Well, I think the most important thing, I don't know, it seems to me, is to have people really have to understand how healthcare works is the first thing. And I think if you if you can't sit in a room with people who are negotiating contracts at Anthem or people who are doing revenue cycle management at a large hospital system and have a really thoughtful conversation about their jobs and why they work and what their core economics are, it's going to be really tough to add a lot of value. And I think the products that are starting to work more and more in digital health are not the ones that are like great experience, but ones that actually change the core economics of the system. And you can't really do that unless you understand the core economics of the system.
Yeah.
So I think that's really critical. And then, just be ready to be told. If you have that really clear, be ready to get told you're pretty dumb for a while.
Got to have thick skin for sure.
Yeah, you got to have that, and then I think you have to be able to handle. I think you have to be able to handle operational complexity in this part of the world, because there are more and more. I think there are certain worlds in which a small tech team can invent a product and it just kind of works at larger and larger scale, and that is less applicable in most parts of healthcare. Much more, it's how do I get distribution right? How do I get operations right? How do I actually take a piece of that does need to be a material step forward, but then build a distribution engine and a customer support engine that actually connects to the existing ecosystem well. So I think that you have to be both a tech founder and an operational founder to be successful. I'm painting with a very broad brush, but that's what it seems like in at least our neck of the woods in healthcare.
What are your predictions for the next decade or so, within digital health? Like, what trends, what changes do you envision?
So, I think you're going to see a few things. I think you'll see a real sort of hollowing out of a variety of most solutions. I think point solutions will just go in network and get folded into hospital systems, et cetera. I think the folks that you'll be left with a few folks who are really able to control risk, and basically what we sort of measure our product on is cost savings per unit of disruption. If you can keep health outcomes at least as good as they are now, but really lower cost without disrupting employees or employers, that's the key. And I think those organizations that are able to do that at large scale will take more risk. And I think there will be a couple new layers of the healthcare world that get created on top of your traditional health system or BUCA apparatus that help do that, both for providers and how they take risk and all of that, and then also for employers. And I think you'll see a couple larger risk-bearing entities come out of the digital health tech ecosystem. But again, the units will be who can control cost without disrupting the apple cart.
Okay. Yeah, I think that makes a ton of sense. I think something that's really important, for leaders within healthcare is to practice what we preach. We live, we breathe, we sleep healthcare. We're constantly like trying to help, our companies grow and do well. But at the same time, like it starts at an individual level. You're in a super stressful job. You're running a company, you're growing, you're scaling, everything's going great. But at the same time, like you're probably pretty low on time. How do you, find ways and time to exercise and reduce stress? What are your favorite ways, to kind of stay healthy, both body, and body?
Yeah, this stuff's it's a marathon for sure.
Yeah.
I log off my phone every Friday when the sun goes down, and I don't log back on to Sunday. So my wife has always asked me for directions on the Saturday. I'm like, I don't know. My phone's at home, So I think that's been honestly a huge thing for me. And then I think people underweigh the impact of all sorts of stimulants and depressants on their body. So I don't do caffeine, I don't drink, and you're like, all right, I'm in, let's go do this thing. And I sleep 8.5 hours a night. And like beyond that, I kind of, that enables me to get some boundaries. I log off work every night at 9:30. I'm back on at 6:30 in the morning, and then I just don't work Saturday, Friday night to
So
Sunday
no
morning.
personal time.
and then that's it. And then, beyond that, I can work. I have an amazing wife who lets me, enables me to work pretty hard here. But
What about exercise? Do you prioritize it, or does just working 15 hours a day do enough to,
I am trying to run a 6-minute mile here, Norm.
Okay.
So I get to the track 2 or 3 times a week, and I run sprints in the track, which is, for me, I'm a pretty goal-oriented person, so it's nice to have like a goal. And one of my employees is a lot faster than me, so I'm trying to catch her.
Okay.
So it's good to have a nice goal, and I exercise 2-3 times a week. I don't have a lot more than that, but doing my best to stay fit here.
All right. Next conference we're both at, probably Conference Board San Diego. I'm happy to go on a run with you.
Let's go.
We'll see what we can do. And then I think like the piece of healthcare that's probably the hardest in the United States is eating healthy. Like if you look at TV advertisements or what pops up on Instagram or whatever, like there is temptation all around with fatty, processed foods. What healthy recipes do you or your wife make that keep you running efficiently and fueling your body and your mind to, work at a, very fast pace and high intensity?
Man, well, let's see. I'll make if anybody wants to write in for the recipe, I make a lentil lasagna. That's
Okay.
really good. And the good thing about a lasagna is you can eat it for like 3-4 days. So you kind of keep, and you make like 2 big sheets of it or whatever. And so that's that's a good thing. But yeah, it's always a battle on the road and all that stuff. But I'll be traveling tomorrow and have a big slice of that in a Tupperware to go.
Nice. All right. Well, I might try the lentil lasagna as one of my recipes for the Healthy Headhunters recipe and food blog podcast, or it's not podcast, a video series. So more on that to come. But, again, Nick, really, really appreciate the time. Appreciate what you and your team is doing over at Garner. Really happy for all the success that you and your team have achieved so far, and really excited to watch from afar and see, how you continue to grow and build, within the space. So again, thanks for joining us on the Digital Health Heavyweights podcast, and have a great day.
Thanks, Norm. Appreciate it.
Thanks. Thank you for joining. Please like, comment, and subscribe below if you enjoyed it.